All right, welcome everybody. I'm Dr. Sandeep Thakar. I'm a neurologist. I focus on movement disorders and Parkinson's disease. We're going to be talking about what's the latest on the horizon for Parkinson's disease management. At the same time, I'll be going through this lecture. Please feel free to ask questions on the comment section. I'll get to those questions appropriately at the end of this lecture. And hopefully, again, this will be entertaining, but also educational. So again, I'm a neurologist. I'm going to be focusing on clinical research, some medical updates, and updates about DBS for Parkinson's related symptoms. So Parkinson's disease, as we know, is a disease state where we're low on dopamine. It's the second most common neurodegenerative disease state behind Alzheimer's. But typically affects motor symptoms. So we typically will see tremor, stiffness, slowness, a very particular type of tremor, very particular types of slowness, and patients present with more unilateral-like symptoms. As you see in the scan there in the top on the left, the normal imaging is you see on this PET scan, it's a very specific type of comma-shaped symmetry. And in these areas are actually the basal ganglia, specifically for the caudate putamen areas. For a patient with Parkinson's, we end up losing the uptake of receptors for dopamine in these areas, and therefore when you see on the picture on the right for Parkinson's, there's an asymmetry where one looks a little bit more brighter and the other side looks diminished as far as the shape. So with Parkinson's, always one side's a little more affected than the other. It's typically diagnosed clinically, as you probably know. It's, again, a disorder of tremors, but 20% of patients actually don't present with tremors. They may have some degree of slowness, which we call bradykinesia. They'll have a quality of rigidity that's very different from a spasticity from a stroke. And it's important to see a neurologist who is well-trained in Parkinson's movement disorders so that you can get an accurate diagnosis. Now, how we track symptoms is something called the Unified Parkinson's Rating Scale, and that's how we decide based on particular symptoms and, of course, the history of the patient, how we need to change medications accordingly. One of the biggest issues we have is barriers for Parkinson's is how do we diagnose it earlier? We have issues where the actual disease state we believe to be is due to a protein that's abnormal called alpha-synuclein. It's these presence of alpha-synuclein clusters that kind of build and spread throughout the central nervous system. As you can see in the diagram on the right, the picture, in the top you see in the red or pinkish color that there's a spread, we'll call it rostral, of abnormal protein that's actually spreading in a particular fashion. And over time it spreads into deep structures of the brain under the subcortical regions, and then it then spreads to the frontal aspects of the brain and then occipital areas of the brain. This is something that you cannot see on MRI, you cannot see on a normal CT scan, and this is usually seen on pathology. So these are abnormal proteins within the brain cells. Now, it's very hard to track these abnormal proteins called alpha-synuclein, and if we had looked back at the stages of patients with Parkinson's, by the time someone's actually diagnosed and presenting with motor symptoms of tremor, stiffness, and slowness, they may have already had these abnormal proteins spreading for at least 10 years. And so we're looking for other ways of diagnosing Parkinson's disease, and those are called biomarkers. We don't have those yet, where we could get a blood test. There's certain types of spinal taps that we could do to look for certain proteins, such as alpha-synuclein and different ratios of tau protein, but that is still not a standard of care. Now, our major barrier, again, as I commented, is how do we diagnose early? And then we don't have great, robust disease models. So we use a rat model, we use different types of other animal models, but that's still not the same degradation and loss of neurons that are affected by alpha-synuclein in the human. We've had amazing results in certain rat models where medications have been able to treat or get rid of alpha-synuclein, and yet it doesn't present and translate to human models. So right now we're working on monoclonal antibodies. There's a specific type called prasinezumab, which is targeting these aggregates of alpha-synuclein. and it's been shown to reduce the levels of this alpha-synuclein by 97%. So we're seeing in studies right now that it could be of benefit. We're looking to see how it actually translates for patients. There's another type of monoclonal antibody that had been studied but came back negative for results that were beneficial for patients for Parkinson's disease. Now, there's different types of delivery systems that we're working on, special types of glycolic acids, the biodegradable polymers that are very specific, liposomes. These are, again, ways of allowing levodopa, which is the main therapy, to be delivered to the brain and last and sustain the effect. The other aspects are other types of dopamine stabilizers, as we see where we have a difficulty of treating all the dopamine receptors. There's at least 5 dopamine receptors we know, and they work in different ratios in different parts of the brain. If Parkinson's was just the dopamine deficiency, it would be relatively easier to treat. However, it's not the only deficient neurotransmitter. We do see serotonin involved. We do see that these alpha-synuclein pathways do affect norepinephrine pathways and acetylcholine pathways, glutamate pathways, all throughout the central nervous system. Now, as we are trying to figure out management of Parkinson's, when we do have medications, we are hitting another barrier, which is the ability for the medicines to work. So levodopa, which again is dopamine and converted, needs to be absorbed properly. With Parkinson's, there's slowness of movement, but there's also slowness of movement in the GI system. So as we swallow, there could be problems. It can sit in the stomach for extended periods of time, even up to a couple hours, before it actually gets absorbed in the jejunum. And the other aspect is that there are other comorbidities. We know that there's other facts of inflammation of the body. We know that in the actual GI system, there may be bacterial infections. We know that H. pylori that may affect the absorption of levodopa. And then when the medication is absorbed, it may not really get into the system at a certain amount that we need. It could be, again, delayed, and then you have 2 or 3 medications building up on each other, which can cause abnormal increase of levodopa with side effects. So there's a lot that needs to be understood. The microbiota of the intestinal system we know is altered. We don't have a very good sense yet as to which is the healthy bacteria and what's been affected over time. But we do believe that the actual disease state starts in the gut and spreads central nervous system-wise up different nerves up to the brain. Now, as the disease progresses, there are other issues where patients may not be able to swallow the medications properly. And so we have to think outside the box, how do we manage symptoms if there's also dysphagia? So first and foremost is, at Hoag, we're part of the clinical trial for IPX203. It's a longer lasting carbidopa-levodopa tablet. It was in a capsule form, and we had finished the phase 3 clinical trials, and it's being worked right now through the FDA as to approval. So it was a 13-week trial. It was blinded, where the patient and the physician were not aware if the medication was being given as the actual dosing of medicine or placebo. And we were looking at the outcomes of how this extended release carbidopa levodopa was compared against the patient's current carbidopa-levodopa immediate release form. So we completed this trial in December. We're waiting for the results. From my experience, it seemed to be quite beneficial for those that we assume to be on the therapy. There's certain ways, of course, as a clinician, that you can maybe see differences of how patients respond to therapy and how they get switched off therapy. So again, we are looking at wonderful results, maybe 7 to 8 hours of response for levodopa. Now, the levodopa tablets that we have currently do not last long, and they may wear off even in 2 or 3 hours. There's another form of therapy called the accordion pill of carbidopa-levodopa, and that was a very unique design, and this medication was meant to slowly release the dopamine within a capsule. However, as of this time right now, it was studied in a multi-level blinded study, but limited results, and did not pass the way we wanted to for extension of a major difference from immediate release carbidopa. So when there's absorption issues, maybe swallowing issues, we need to understand that the medication kicks in, it wears off, it kicks in, wears off. Patients need to be on this medicine 3, 4, 5, even 8 times even a day because it doesn't absorb well and it wears off quickly. So we are in a wonderful time of modern medicine where we're able to now get levodopa into a subcutaneous form. There currently is something called Duopa, which is a duodenal jejunum pump, and that's a procedure that needs to be done by a GI specialist where we can deliver the medication through a pump. Now we're talking about subcutaneous, so this is through the skin, and AbbVie is working on a current model of subcutaneous levodopa called ABBV-951, and this again is been completed at phase 3 clinical trials. We're waiting for the results for that to be approved by the FDA. And so patients will not have to worry about the medicines kicking in and wearing off, kicking and wearing off. This will be, again, a dopamine or levodopa pump where we'll get more smoothness throughout the day. And again, we've been years behind the endocrine world where insulin has been in a pump model. We're now developing such therapy which will make life easier for patients, avoid the pill burden that patients have to deal with, and avoid the off time periods. There's also another type of carbidopa-levodopa subcutaneous infusion that's being worked on, and this is ND0612, another, again, comparator to oral medication, and again, we're hoping for this infusion of therapy to, again, be successful. So we have numerous types. There's also going to be something called Infudopa sub-Q, and this, again, is a third type of formulation that allows for carbidopa-levodopa to be delivered. We're working right now on the safety aspects of that, and we'll develop more results as time goes on. But we're hoping for, again, the adequate levodopa concentrations to be reached for patients to actually have benefit. So that's the subcutaneous form of levodopa. There's also another type of dopamine agonist called apomorphine. This currently already exists in an injectable form for quick effect of the off-time symptoms of tremor, stiffness, and slowness, and there's also a sublingual form already existing. That sublingual form is called Kinmobi. We utilize it again as a film that's under the tongue, dissolvable. It has its limitations for some patients. You can't have that too often. It could cause ulcers or dry mouth or irritability, so we use it again intermittently if needed. Now, the apomorphine infusion pump, there's a study called the Toledo study, and it demonstrated that apomorphine infusion did help the motor fluctuations of patients with Parkinson's. It was an open-label phase study that was an extension to it, 64 weeks, that did not have any unexpected safety signals or concerns. It did reduce the off-time symptoms, which are the tremor, stiffness, and slowness, and allowed for an improvement of patients' motor control without troublesome dyskinesias, those involuntary movements when patients are getting too much medication. So we are again seeing the formulations of medicines coming out where, again, much more smoother, less dependence on a pill wearing off, and then that allows for more autonomy for patients. And these pumps are going to be where a patient or family member can actually put it in their own skin in areas where it's not a major procedure or surgical intervention. Now into some clinical trials. There was a study that's being done that's looking at small intestinal bacterial overgrowth, also known as SIBO, in patients with Parkinson's disease. It's to test the hypothesis that if SIBO is there in the system, then can we treat the patient with Parkinson's disease with antibiotics, and will that improve the motor complications that patients suffer because the pills aren't absorbing? So SIBO can cause some inflammation. That inflammation, again, will irritate the gut lining, which may prevent proper absorption of therapy. Parkinson's disease, as we know, is a motor fluctuation disease. We need to screen for SIBO, and there's different ways of testing for it with hydrogen breath tests. So if we're having limitation where the meds aren't working or all of a sudden they're not working well enough, there's a lot of constipation issues, we have inappropriate on times, then this is when maybe we need to look into such symptoms of SIBO. The hot topic for many, many years has been stem cells, and I want to make sure that I prime this, we are still far from actually understanding the benefits of stem cell research. Now, there's different types of stem cells. Right now, I'm going to talk about one specific one, which is a single-site phase 2A study. This is looking at allogenic stem cells. These are, again, mesenchymal stem cells. And this is a type of cell that has pluripotency. It can, again, create any type of stem cell. It's being studied where it's put into certain areas of the brain in the basal ganglia. And this has been right now studied significantly at the University of Texas. The purpose, again, of this study is to check for safety and efficacy. And we're going to see if there's any sort of benefits for the Unified Parkinson's Rating Scale. Is it able to maintain dopamine properly? And then are there issues where, is there any increase in maybe dyskinesias or infections or other concerns of maybe even cancer? So we do have to preface it. This is still something in the works, and we don't have the ability yet to say if stem cells is going to be the mainstay of therapy in the future. There's also some studies right now in Europe, in England, that is being studied with deep brain stimulation, where at the site of the lead being implanted for the actual DBS surgery, they're putting stem cells there to see if there's some changes actually at the level where the stimulator is allowing for better communication and signaling in the basal ganglia. So Parkinson's disease, we believe, again, is an inflammatory disease. It may be due to this inflammation that's due to the alpha-synuclein. There may be other causes as well. What we're looking also is how insulin may be able to reduce that brain inflammation. What we do know is intranasal insulin can be used in other disease states, and we know that it's in a similar design right now being studied for other dementias. Now, there's a study for Parkinson's disease. It's being conducted also for Alzheimer's and mild cognitive impairment. There's different low doses that the intranasal insulin can be given, and even at higher doses it's found to be safe in healthy adults. What we have known is prior studies performed did demonstrate favorable effects in mild cognitive impairment and the Alzheimer's population without getting low glucose levels. So hopefully we can find that if there's reduced inflammation in a patient with Parkinson's, there may be improvement of their symptoms. Going into the model of, again, understanding the endocrine world, inflammation, there are other medicines that exist that we use for multi-purposes. So there's liraglutide, which is a glucagon-like peptide. We call it GLP-1, and it's naturally occurring throughout the brain. We're looking to see if we can utilize this therapy and to stimulate certain areas of the brain with patients with Parkinson's. So again, these are stimulating the release of insulin. The component here is, can we reduce the inflammation that is developing over time? So this can, again, reduce the resistance against pathogenesis of what we believe to be the alpha-synuclein and spread of it. There's different signaling that, again, causes a spread of this alpha-synuclein abnormal proteins. And what we're understanding is if we can reduce that inflammation, maybe we're blocking that degradation of the pathway and spread. Another type of GLP-1 agonist named exenatide was studied already, and it showed that it did significantly improve motor and cognitive symptoms. We believe that maybe this type of therapy may be even more superior than exenatide. Now, some medicine that already has been available, currently came out during COVID, is opicapone, also known as Ongentys. It is FDA approved, it is available. The reason I bring this up is it is a COMT inhibitor, COMT inhibitor, which again allows for reducing the breakdown of levodopa. If we can minimize the metabolism or breakdown of levodopa, then we're keeping more levodopa into the system. And so opicapone has been used, we utilize in our clinic to help with the fluctuations between doses. It's given as once a day at night, and it helps for daytime symptoms as it kicks in. The graph there shows how it was showing an improvement versus placebo versus another COMT inhibitor called entacapone, and in patients who were on Ungentis, over time in 12 weeks and 14 weeks, you saw an improvement of their motor symptoms. So the lower it goes, the improvement of their symptoms. And you saw over the extension phase of 52 weeks, it continued to show benefit for motor symptoms. So we've been very pleased with any type of therapy that allows for keeping levodopa in the system. This is another perspective of where when you take a medicine like Ungentis or any other booster, we're lifting up the amount of levodopa in the system without giving more levodopa. And if we're giving too much levodopa by itself, we could cause complications such as dyskinesias, hypotension, maybe even hallucinations. So if we can minimize the need for more and more levodopa, and we can give certain boosters, we're smoothing out the symptoms. And as you can see, there's an improvement in the peak of the medication, but also it doesn't wear off as fast. So these are, again, important factors. More that's been learned is Parkinson's is purely not a dopamine deficiency, right? There is other receptors involved. Adenosine is another receptor that we do see that is hyper-regulated actually in Parkinson's. So what we see as the disease progresses, in the lower PET scan, you see adenosine receptors are upregulated in a patient with Parkinson's as they're progressing. If you look at the top picture of the PET scan on the top right, this is of a normal patient without Parkinson's. And when you compare again someone who has developed Parkinson's over time, you see that the red, the increased hyperactivity, is suggestive that these are areas in the globus pallidus that is causing muscle rigidity and stiffness. So we now have a therapy that's very specific to target these receptors. The medication that we have and is FDA approved is called istradefylline, also known as Nurience. It's been in Japan for numerous years, and it was indicated for off-time symptoms in patients with Parkinson's already on levodopa. So it's a brand new type of therapy, or new novel type of therapy that is non-dopaminergic, again trying to promote the need for medications that are not just giving more and more dopamine with complications that may come with it. And it's very specific for another receptor, which then again allows for no interaction with actual other dopamine receptors. What you see in the MRI scans right here, these are special functional scans. So the first set, when you look at with the red, is a patient who is on, not with any form of istradefylline. The MRI right next to it in the blue, that actually is saying that those areas are quieter, and that was on 20 milligrams of Nurience. If you look at the far right, where there's less blue activity, that's again a cooling area where the globus pallidus is reduced in its hyperactivity, and that's a patient on 40 milligrams of istradefylline. So we do see that this medicine is very specific, targets these receptors, and reduces symptoms in patients with Parkinson's. Now, for most of our patients who need more and more levodopa, it's usually after we can't control tremor. What we do see is tremor really interferes with handwriting, eating, dexterity issues. So we've been using a lot of botulinum toxins for the muscle rigidity or the dystonia that's developing that causes the spasms to eat properly, to write, and people, as you're writing it, we know that the penmanship gets smaller. So we've been able to utilize Botox-like therapies. And if you look here, this is a picture on the left where I had a patient draw spirals. And so as you can see on the right hand, a lot of undulations, very high amplitude spasms. On the left hand, not as much, but still a good amount of spasms where the tremors were interfering with smoothness. So this was again before injecting any Botox. When you look at the same patient after being given Botox injections in very specific muscles, we were able to find that there was a reduction of those. A patient, if you see, after just almost 2 weeks, in the right hand, where we only injected in the right hand, there was an improvement where the patient could now coordinate very well and draw within the lines without the significant difficulties. That patient, I can tell you, was planned to have deep brain stimulation surgery. We were able to have the patient continue with Botox every 3 months, and she still continues to come see us over this time period. As I want to comment, the right side, the right hand was actually injected, the left was not, but as such a proponent of the body shaking from the right hand, it caused her whole body to shake, that she actually, you can see an improvement of the left side where she's not as shaky with the combination of both hands being involved. Now, talking about surgery, deep brain stimulation, DBS is also referred to. We know for 20 years it's been utilized in certain areas of the brain. We have two main areas for Parkinson's, the globus pallidus and the subthalamic nucleus. It is for the off symptoms of Parkinson's that treat tremor, stiffness, and slowness, that it's going to be responsive for patients who do well with levodopa. So if you do well with levodopa, these are the symptoms that will be improved if you had deep brain stimulation. Now, if there are certain areas like balance issues, they may not be responsive to deep brain stimulation. It could even make it worse. But if the responsiveness to levodopa improves certain gait and balance issues, there could be some utility of deep brain stimulation helping. So we utilize it when medicines are not functioning well for the patient, or it's too cumbersome, they're getting dyskinesias, they're getting abrupt off time. And what we're understanding again is that this is just like a pacemaker surgery like you would for the heart, except for the leads go to the brain and the subthalamic nucleus. You don't have to shave your head now. The surgeons are very well equipped in knowing how to make a nice incision and then putting in this very spaghetti thin size wire that again at the end has an electrode to send very low current to signal the brain cells and neurons to then drive the pathways that have been affected by the alpha-synuclein. So here's an example, as you can see, of the lead in the structure of the brain. This is, again, just a redemonstration of where we're putting the lead into the globus pallidus. And again, the surgery, again, it allows for stimulation to re-excite those areas to fire properly. So we have a little battery in the chest wall. It's all under the skin. The wire is under the skin, and it goes into the area of the brain that we need it to. What's very unique now is that there's an area in the brain that we know is where there's bad activity. We call it the beta activity. That's where the signal is being sent that's causing the tremor, stiffness, or slowness. Predominantly more of the rigidity and slowness. So deep brain stimulation has become very unique, where we're not now just sending the signal. We can actually listen to the signals, find out where those abnormal signals are. And if you see in the diagram at the bottom, that beta wave, that little signal there, that's actually where the abnormal signal is. So we can actually change then the stimulation, allow for a higher stimulation around contact 1 and 0, and we can then dampen that abnormal beta wave. And so now we're getting into effect of actually understanding where the brain signals are abnormal. So short term, we help symptoms for patients' tremor, stiffness, and slowness. It allows for reduction of medications when you have deep brain stimulation. We know that patients can then utilize medicines later on if they need to. Deep brain stimulation, again, needs to be done in a very highly specific manner. It needs to be done at centers that actually do it on a regular basis. But over time, it does help improve on-time periods, and it can help control dyskinesias if done at the right location. Now, I commented about the technology that exists. We can sense brain waves. On the left is the highly erratic beta waves that we saw of a patient over a span of October 8th through October 16th, and this is in 2020. I'm just showing that the timeline, if you look at the patient over that same time period and weeks later, you can see a dampening of those signals. Well, that's because we can now find those signals and dampen it by changing the stimulation. When we lower these abnormal beta waves, it does correlate with symptoms being better controlled. Here's another example of some very excitable beta waves in an area of the brain in the subthalamic nucleus. We're able to, if you see, control the signal. If you look at very carefully at the pink and dark black lines, it's showing the little box squares. It's actually a higher voltage that's being delivered, and you can see now a suppression of those beta waves where the blue is a lot lower, and that corresponds to the left part of the brain, which is right symptoms. Now, in our area, there's, and in numerous areas around the country, they're utilizing gamma knife MRI guided focus ultrasound. And this could avoid a craniotomy, potentially, for patients who don't want to have deep brain stimulation. Now, the concern about this is it's still unilateral. It's something that if we had a bilateral system or bilateral gamma knife, it would cause some significant swallowing issues. It may create balance issues. There are still concerns of this gamma knife as it is irreversible. If you are burning these areas and using ultrasound to destroy these areas that are causing tremors, well, we don't get that back. Now, with deep brain stimulation, that's the counter aspect, is now we know where the signals are. We can dampen those signals without killing those areas of the brain because we could have some limitations. So get into the portion right now of questions. If you do have questions, please write it in the comments section. I do have some questions I'll be answering. So one of the questions is, how do I determine when to start a patient on medicines? It's said I have seen some people start meds with minimal symptoms. So one of the key aspects about medications is all about quality of life. If there are symptoms that are tremulous, rigid, affecting balance, we need to determine how is it affecting quality of life. If there's a little bit of thumb tremor, I wouldn't want to start some strong medicines. We always want to treat the symptoms with the appropriate amount of medicines. Now, I have a lot of patients, when I talk about therapy, it's not just oral tablets. We're talking about it must be therapy with exercise, diet. We have to look at how sleep patterns are affected. There's a lot of patients who may not do well with certain sugars, so they may not do well with not sleeping well at night. They may have apnea, and then they wake up tired, fatigued, and that can exacerbate their symptoms. So symptom decision making as to what we want to utilize is based on if you can't do the quality of life measures you need. It's hard to eat. It's hard to write. We're having issues at work. Our dexterity for typing isn't good. Or again, one of the most important things I would highly suggest is when balance is involved and we're at a risk of falling, that's a big need for starting therapy. One of the other factors is if there's swallowing issues, concerns of aspiration, that may be another reason to consider therapy. If there's any questions, please feel free. I know we're live right now, but don't be shy. We got a few questions coming in, as we can see. I appreciate everyone who's logging on today, and you'll be able to access this video also later on or pass it on to others who may have not been able to access it today. I appreciate the Hoag team and marketing at Hoag to help promote education. This is something that is near and dear to us. Now, I didn't get to go over all the different new therapies that exist. There's a lot of different types of therapies that do exist in clinical trials. I did speak on certain ones that I thought were appropriate. Coming in is another question. So the question is, does any diet regimen affect the process of Cinemet being utilized in the body? Now, the important thing is Cinemet is also known as carbidopa-levodopa. It is a amino-based type of therapy. So what happens is it needs to get into the receptors and absorb at the sites where protein is also absorbed. So if you have fish, bacon, eggs, certain types of high-rich protein in your diet, it will block the absorption of levodopa. So we try to tell patients, take this medication either before a heavy meal, 15 to 30 minutes before. If you really are sensitive to the meds not absorbing, then maybe even 60 minutes before a high protein rich meal. Some patients may get nauseous, have upset stomach or headaches when taking on the medicine on empty stomach. So maybe take it without protein, some bread, crackers, some carbs or good fats. There is no specific diet that we say a patient should be on, but we do know that if someone has allergies to gluten or sensitivity, then again, that's something you may want to change your diet to being conforming to what's reducing inflammation. I do have a lot of our patients become more vegetarian. We have seen that helped the GI system a lot. We don't know what is in the preservatives of our chicken, our beef, the hormones that are being put in there. We do see that pesticides are a big deal as causing inflammation and higher rates of Parkinson's disease. So again, there is a lot of animal meats that have by history caused illnesses. We don't know if that environmental toxin is part of it. As we saw with COVID-19, we believe it to be part of, again, some relationship to animal meat, and that's where it may have started. There's still a lot of questions about that, right? So another question is, how important is the time between med doses? My husband and I are on a 3 times a day dosage. There are times we take them more than an hour apart than before. So timing, again, is all individualized. It takes about anywhere from 22 to 40 minutes for the levodopa to actually get into the system and be of effect. And then it can wear off depending on what you ate, how much it was given. If you're constipated, it may not absorb. So we start off with every 5 to 6 hours between doses. So maybe someone's taking their medication at 8, 1, and 6. And then you want to look at the intervals of maybe 15 minutes, 30 minutes, an hour before your next dose if the symptoms are coming about. Those are key comments that if you notice tremor an hour before you're due for your next dose, maybe that means we need a booster or change the timing or of the medications, or maybe make it more frequent. I would definitely talk with your doctor about how to adjust for that. You don't want to stack too much medicine close together, or you don't want to just double up the pills, because again, that's where we can get dyskinesias or abnormal involuntary movements over time if we are over-medicating. Going back into questions of medicine, does medication help to slow progression of symptoms? Is that one of the benefits? So we don't have currently any medicines that can say by the FDA that we are able to slow the progression of symptoms. What we do know is that there was a study that showed that levodopa can be started early if it's utilized for activities of daily living. It did not show that it was creating a decline or worsening of the disease state if you started levodopa early. It did show that when levodopa was started, the quality of life was much improved for patients symptomatically. So in my opinion though, if you are on therapy and medicines and you're feeling like you have good balance, you're stronger, you're less stiff, then it allows you to exercise more. I think that's, again, the key aspect is to slow down the progression. It's all about exercise, so get into tip-top shape, be well managed. That will be key. What about memory and cognitive issues? There are a lot of issues that can develop with Parkinson's over time. It's not the typical memory issues that you would think of short-term recall with Alzheimer's. Parkinson's disease affects verbal fluency, difficulty getting words out. It can affect patients with multitasking. Some of our patients have a difficulty with sequential tasks or procedural tasks, like step 1, step 2, step 3. So again, it's always key about slowing things down. I do recommend that reading out loud to help the vocal muscles. And then again, if someone asks you a question or asks something and you want to have to remember it, repeat the question so you can again hear yourself answering it. So for instance, we have a lot of our patients who are asked by their spouse, can you go get this from the fridge, and then also don't forget to bring that back. Well, if you just repeat it out loud, you're teaching yourself to recall what the tasks are. So there's a lot of different tricks that could be done. I definitely think that talk to the neurologist about cognitive testing, getting a baseline neuropsych testing to see where the deficits are. Usually we don't have deficits with executive thinking with Parkinson's, but again, verbal fluency, visual spatial aspects where we can misinterpret what we see, and that's again another cognitive processing issue. The question is about infrared light therapy. Well, there's a lot to be learned right now about infrared light therapy. There's different frequencies of light that may help symptoms. We know that there was a study that was done with a mouse model that showed that it was able to reduce dyskinesias. There's belief that infrared light therapy may help with depression, and there's another study that's being studied for how it helps Parkinson's patients with sleep. I can't comment about that yet. We're still understanding that more, but I do believe that, again, there's an importance of how we take in certain sensitivities, and infrared light therapy may be something that's useful. There's a patient who says, I'm a type 1 diabetic and a heart patient. Does this have any impact on potential treatment? Well, There are, again, important factors, as I talked about. There's a lot of studies being worked on inflammation and understanding how to keep sugar levels low. Inflammation is the key. Again, if it's GI inflammation, it could be patients having problems with dairy. It could have issues with certain foods or nuts. Again, with diabetic patients, you can't tolerate, again, the control the sugar levels. This, again, is going to affect patients' inflammation. We do know that if there's complications of a health issue, it will impact the Parkinson. So for instance, if someone has high glucose levels and it drops significantly, patients with Parkinson's feel very weak, very tired, they have a reduced energy. If someone has hypertension and then you're giving some medicines to control the hypertension, they become too low in blood pressure, then again, there's a lot of dizziness and falls. So again, you want to treat each and every disease that someone is suffering, keep it into a well-managed aspect. Another question, this is about a specific medicine called Nupro, also called rotigotine. It's a patch, and it says, does Nupro help with balance or just restless leg? Well, it helps with restless leg for sure. That's what it was studied for, but dopamine is utilized as a therapy for restless leg. As far as balance goes, dopamine, it's all dependent. If this is about stiffness and slowness that's creating a balance or imbalance, then if Nupro is given at the appropriate dosing, it could help someone's reaction time, agility. However, if a medication such as this is given at too much of a level, people can feel dizzy or lightheaded. We have seen that Nupro, like other dopamine agonists, could also slow down thinking in patients 70 and older. So sometimes we utilize this earlier in the disease state. These are all great questions. I want to thank you all for the time. And again, keep learning, keep your ambition up about getting better. And again, ask any questions you may have with your neurologist. Have a good night.